Hello everyone and welcome to RADS.110, Radiographic Procedures. In this course we learn about anatomy of different body parts, and then we learn about the radiographic positioning of that part. And that's the format that we're going to take as we progress through this procedures course and then all of the rest of the procedures courses in this curriculum. We'll learn the anatomy of the given part, and then we will progress and learn the positioning of that part. So let's go ahead and begin. And as we begin our talk about radiographic positioning, one of the first things that we need to talk about are what are called planes of the body. So here you see this man, and he is being sectioned off using different planes. Okay, you can see that there is what's called a sagittal plane, and the sagittal plane is going to divide the man into right and left sections. You see a coronal plane, which is going to divide the man into a front and a back section. And you see a horizontal plane, which divides the man into an upper and a lower section. And then an oblique plane is a plane that passes through the body at an angle. So these planes of the body are very, very important. We use them all the time when we're talking about radiographic positioning. We see the man, and the man is positioned in what is called the anatomic position. Okay, the anatomic position means that your patient, or in this case the drawing of the man, he is facing forward, and notice his palms. His palms are also facing forward. And that's going to be very important when we learn some other terminology, especially what's called medial versus lateral. Okay, so a couple of points to get out of this slide. Notice the way the man is standing, the anatomic position. Notice the planes, sagittal plane separating the body into right and left sections, coronal plane, front and back sections, horizontal plane, upper and lower sections, and then an oblique plane coming off at an angle through the body. Here we're looking down on the man, and you can see that we've got a sagittal plane. And notice a sagittal plane, it simply cuts through the body and gives you a right and a left section. Okay, it doesn't have to be right in the middle of the person. Okay, in this case, you can see the sagittal plane is cutting through his shoulder area. Now, the sagittal plane could cut through the very middle of his body, in which case then it has a special name called the mid-sagittal plane. Okay? And a mid-sagittal plane, and I want you to listen to my terminology, a mid-sagittal plane cuts the body into equal right and left sections. Okay, so if that plane, that sagittal plane, were right down the middle, we'd call it a mid-sagittal plane. We abbreviate that MSP, mid-sagittal plane, and that divides the body into equal right and left sections. But a sagittal plane in general simply divides the body into right and left. Same thing with a coronal plane. Here we have a coronal plane, okay, which is cutting through the body and giving you a front portion and a back portion. Now we could have a mid-coronal plane. Now the mid-coronal plane, imagine it would be a plane that would be passing through the head and actually going through the armpit region all the way down. And that's going to divide the body roughly into equal front and back sections. Okay, so that would be a mid-coronal plane, or MCP. Okay, so sagittal planes, once again, right and left, and coronal planes, front and back. So let's read here. It says top-down perspective of patient's body showing a sagittal plane through the left shoulder, a coronal plane through the anterior head, And then if you look, coming off at an angle, an oblique plane through the right shoulder. Talk a little bit about body cavities. Okay, you can see that there are two main body cavities. Okay, and these are in the torso region. We've got the thoracic cavity, and the thoracic cavity is where the patient's lungs and their heart is going to be. And then we've got the abdominal cavity, which is going to be all of the organs of the digestive system, uh, reproductive system in the female, the urinary system, the kidneys, the ureters, the bladder, okay, all in the abdominal cavity. Notice in parentheses there's abdominal pelvic cavity. This is sometimes used by anatomists as well in talking about the abdominal cavity. It's that combination of abdominal and pelvic cavities. You'll notice on the drawing too, it says pericardial cavity. Peri, we'll talk about this in med term. Peri means around, cardial pertaining to the heart, so that area around the heart, that cavity where the heart is going to be. And then your pleural cavity is where the lungs are going to be. So here we have an anterior view of the torso showing the two great cavities, the thoracic and the abdominal. Now what separates the thoracic from the abdominal cavity is the patient's diaphragm. And the diaphragm is a very large muscular partition that separates then the thoracic from the abdominal cavity. Let's talk about dividing the abdomen. Okay, now this is going to be very important because in radiography, when we are going to x-ray a patient, we're going to take what's called a history. And we're going to ask, for example, where is the patient having pain? Now, if we're talking about the abdominal area, we can break the abdomen into different what are called quadrants. Take a look at the blue lines here and where they are going to intersect. So we're going to see basically a sagittal plane coming down, and then we've got a horizontal plane going across, and these are going to meet at the patient's umbilicus, their belly button. And when we have those planes intersecting, then we form four what are called quadrants. And we've got the right upper quadrant, or RUQ, the left upper quadrant, or the LUQ, the right lower quadrant, or the RLQ, and the left lower quadrant, or the LLQ. And it is appropriate, and we do use these abbreviations when we're documenting histories on requisitions. So if the patient's telling you they've got pain by their liver area, which is on this drawing, that brown area, then we would say patient states pain to the RUQ, the right upper quadrant. There's another way that the abdomen can be divided, and this is by the use of what are called Addison's planes, in blue here. And it divides the abdomen into 9 what are called regions. Okay, you can see that we've got what's called the right hypochondrium. Hypo means below, chondro, ribs, so that area below the ribs on the right side. On the other side, we got then the left hypochondrium. Then we've got the epigastrium. Okay, epi means upon or above. Gastrium, the stomach, so you can see the stomach. It's drawn in there for you. You can see that's a region by the stomach. Then we've got a right lateral, sometimes called the right lumbar, left lateral, sometimes called the left lumbar, and then the umbilical region. And then we've got the area down in the pelvis, the right inguinal and the left inguinal, and then the hypogastrium, hypo meaning below, in this case way below the stomach area. So these are the 9 regions of the abdomen. You may see when you're looking at a chart, surgeons, nurses, sometimes they identify pain using the 9-region system. But as far as radiography is concerned, we use the quadrant system. Okay, so if you're going to be identifying where pain is for the abdomen, you're going to be using the quadrant system, not the 9-region system. But you do need to know the 9 regions because, like I said, it may be written on a chart. It may say patient is having pain in the left hypochondrium area. So you would know then what area in the body this would be. In radiography, we position by palpating or feeling the patient, touching the patient, and there are different organs at different levels, different structures at different levels that correspond to the vertebral column. So when we look at this, we can see that your Adam's apple, which is called your thyroid cartilage, would be at the level of your 5th cervical vertebra. So I want to point out at this point in time there, and you should know this, there are 7 cervical vertebrae, and the first one is up by the base of your skull, and then we count down. So we've got C1, which would be up by the base of the skull area, C2, C3, C4, C5, C6, C7. Then we start with our thoracic vertebrae, and the numbering starts T1 or thoracic vertebra number 1, thoracic vertebra number 2, all the way down to thoracic vertebra number 12. So you have 7 cervical vertebrae, you've got 12 thoracic vertebrae, and then we enter into our lumbar region. In our lumbar region, we have 5 lumbar vertebrae. So numbering starts again at top and goes down. So L1, L2, L3, L4, L5. And then we've got our sacrum. And there are, although the sacrum appears as one bone, because when we're an adult, these different segments have fused together, you can still see the segments if you look at a sacrum. And we call these sacral segments, or S1, all the way to sacral segment 5. So you have those sacral segments, and then you've got a very small bony structure called your coccyx, or your coccygeal segments, and those are what we know in layman's term as the tailbone. So the point being, and you can see this here, that these vertebral levels are going to correspond to certain areas on the body. Now, why is this important? When we're taking an x-ray, we need to know where to put the middle of our x-ray beam. We call this middle of our beam the central ray. And it may say in Merrill's, put the central ray to the level of T7. Well, that's fine, but how will I know where the level of T7 is? Well, if you go to your shoulder blade, which is called your scapula, and you feel the very tip of it, the very tip of your shoulder blade is at the level of T7. So if it said in your book to place the central ray at the level of T7, what you would do is you would palpate or feel the tip of the scapula or the inferior angle of the patient's scapula, and you would know then you are at the level of T7. T9 and T10 are thoracic vertebra 9, thoracic vertebra 10. That's at the level of your xiphoid process. Xiphoid process is going to be important, for example, if you do CPR compressions. You'd have to feel that xiphoid process and for correct placement of the hands for compressions. So let's go over these because these are very important. So we've got C1 at the level of your mastoid tip. Now your mastoid tip, if you go behind your ear and you feel there's a bony structure, it almost comes to like a little triangle. The very tip of that, that's called your mastoid process. The very tip of it is your mastoid tip. That's at the level of the first cervical vertebra, or C1. C5 is at the level of your Adam's apple or your thyroid cartilage. C7, that's at the level of something called your vertebra prominens. I want you to take your hand and I want you to put it at the base of your neck. So right where your neck is going to join your torso. And if you feel in the back, you're going to feel a bump. And that bump is the vertebra prominens. It's actually the spinous process of the 7th cervical vertebra. So C7 is at that level. T2 and T3 is at the level of your jugular notch. So if you feel your collarbones and you go into the middle, you get to this little notch. That's called the jugular notch. That's T2, T3. The inferior angle of your scapula, that's what I just talked about. In fact, if you put your arm and you reach behind you, your scapula kind of pops out away from your body, and you can actually feel the tip of it. That's the inferior angle of the scapula, and that's T7. T9 and T10 is your xiphoid process. L4, L5, the area where the 4th lumbar and 5th lumbar vertebrae is at the level of what we call the superior aspect of your iliac crest. Now that's a lot of terminology there. It's basically the top of your hip bone. Okay, so if you feel the top of your pelvic bone, what we call your hip bones, okay, that's your iliac crest, the superior aspect or top aspect of it. That's at L4, L5. Sacral segment 1, sacral segment 2, S1, S2 is at the level of the ASIS. If you feel the top of your hip bone, the top of your iliac crest, and then you go forward, you're going to feel a little bump in the bones there, okay, on each side. That's called your ASIS, or your anterior superior iliac spine. That's at the level of S1, S2. Now in radiography, we use a lot of these, but we use the iliac crest a lot, and we use the ASIS a lot. Let's do a quick review. C1, mastoid tip. C5, thyroid cartilage. C7, vertebra prominens. T2, T3, jugular notch. T7, inferior angle of scapula. T9, T10, xiphoid process. L4, L5, superior aspect of iliac crest. S1, S2, anterior superior iliac spine. Something else that's very, very important in radiography is the size of your patient. And the size of your patient is what we refer to as the body habitus. What we call average patient would be what's termed the sthenic, S-T-H-E-N-I-C, sthenic patient. And then you've got a couple of extremes. In this picture here, we have the hypersthenic and we have the asthenic. So your hypersthenic is the larger build person. The asthenic is the thinner sized patient. And what's important here is that the organs actually change position based on the body habitus. So for example, in a hypersthenic patient, the patient's stomach is high and a little bit more horizontal in placement. Whereas in the asthenic patient, the stomach is going to be very long and J-shaped in the body. Take a look at the lungs. Hypersthenic, the lungs are short, but in your asthenic patient, the lungs are longer. Now this is going to be important when you're doing positioning because you may have to make some modifications in where to put your central ray or the middle of your radiation beam based on the habitus and the organ then that you're going to be radiographing. Parts of the skeleton. So here we've got the skeleton and we have broken the skeleton up into two major sections. In A, we have what's called the axial skeleton. So your axial skeleton is going to have your skull, your vertebral column or the bones of your spine, your sacrum and your coccyx, the ribs and the sternum. In B, we call this the appendicular skeleton. And your appendicular skeleton consists of your shoulder blades, which are your scapulae, your collarbones, which are your clavicles, then all of the bones of what we call the upper extremity. So the humerus, the radius, the ulna, the carpals, the metacarpals, and the phalanges. You also have the hip bones on each side. You have the femur on each side. You've got the kneecap, which is called the patella. You've got the tibia and the fibula on each side. And then you've got the tarsals, the metatarsals, and the phalanges. So axial skeleton and appendicular skeleton. Their book talks a little bit about osteology. One thing we need to understand is that bones are alive, and the other thing about bones is that they have a blood supply, a nerve supply. In fact, when you look at the inside of a long bone, you can see that it's actually kind of looks like a sponge. In fact, we call it spongy bone. On a radiograph, this shows up as what's called trabeculae. Also, in a growing bone, we have something called an epiphyseal line or epiphyseal plate. That's actually where the bone is going to grow from. And on children, because the bones are still growing, you actually can see this epiphyseal line. It almost looks like the bone is broken, where it's split off from the rest of the length of it. But that's normal. That's the growth plate area. And then around the bone, we've got a very hard covering called the periosteum. In your long bones, you also have a very large cavity down the middle of the bone, which is called the medullary cavity, and this is where your bone marrow is at. As I mentioned, on the inside of the bones is the spongy bone. And if you look at this radiograph here, and if you look closely, you can see these areas, these little, they almost look like little honeycomb kind of patterns within the bone. Those are the trabeculae that you're seeing within the bone. And when we take an x-ray, in order to determine if we have what's called the right technique, which means it's not too dark and it's not too light, we should see these bony trabeculae. If we see the bony trabeculae in the bone, then we've got the right technique. So as I mentioned with bone growth occurs at what's called the epiphyseal plate or epiphyseal line area. And the mid portion of the bone is called the diaphysis. So you've got the diaphysis, and then at each end, an epiphysis or epiphyseal plate. Here we have an example of bones for a child, and you can see what I'm talking about here. It almost looks like a break where one part of the bone is like broken off from the shaft or the body of the rest of the bone. But that's normal. This is a child. This is an epiphyseal plate. Now, if you saw something like that in an adult, there'd be something majorly wrong, because as adults, our bones are grown, we're fused together. But these are the growth plate areas for children. We can classify bones by different names. So, for example, in our body, we have long bones, like our humerus, which is in the arm area. That's a long bone. We have short bones, and these are the bones of our wrists, our carpals, or the bones of our ankle area, which are our tarsals. These are short bones. We have our sternum, which is the breastbone. That's a flat bone. And here's a picture of a vertebra. A vertebra, bone of your spine, is an irregular bone. Here's the patella or kneecap. and it's called a sesamoid bone. So bones are classified by their shape: long bones, short bones, flat bones, irregular bones, sesamoid bones, and now we move to joints. Okay, for joints are the articulations between the bones, so where the bones are going to come together. And we have functional classifications. In our skull, for example, the bones of our skull grow and they grow together, but these joints, they don't move. These are called synarthrodial joints. They don't move. There's no movement at these joints. So the bones of the skull where they come together. Amphiarthrodial joints provide very slight movement. The best example of this would be an area where your two hip bones come together in the front and meet at something called the pubic symphysis. There's a little bit of cartilage between the bones, and this is going to allow for a little bit of movement, not so much for the male, but for the female during childbirth. That's called an amphiarthrodial joint, or slight movement. The majority of the joints in our body are called diarthrodial joints, and these are freely movable joints. These are joints like at our elbow, our knee, our hip. These are joints that are freely movable. They've got a capsule around them that contains lubricating fluid called synovial fluid, and they allow our joints to move very easily. Now, there's different types of synovial joints. We've got gliding joints, which are examples intercarpal and intertarsal. So the bones in your wrist and the bones in your ankle, when they move, they glide over one another. So we call them gliding joints. Hinge joints, well, you think of like a hinge of a door. It opens, it closes. Think about what your elbow does. We call this flexion, extension. Knee, same thing. This is called a hinge joint. Pivot joints. Pivot joints allow a part to pivot or to turn, like the joint in your cervical spine region, C1 and C2, which allows you to move your head side to side, a pivot joint. An ellipsoid or condylar joint. This is a special joint that has a rounded portion. The radiocarpal joint or your wrist joint is this type of a joint. A saddle joint, it's called that because it looks like the saddle you'd put on a horse. This would be some terminology you don't know yet, but your first carpometacarpal joint. It's where your thumb basically is going to meet with your carpals, and it allows your thumb to move in all different directions. I mean, you could do this and see this. You can move your thumb one way, the other way. You can put it in a rotational type of movement. This is called a saddle joint, and it's in the thumb area. And then we've got ball and socket joints. Sounds like a ball fitting into a socket, like your head of your femur fitting into where your hip bone is, or where your humerus is going to fit into your scapula. So the hip and shoulder joints are ball and socket joints. Fractures. We deal a lot with fractures in radiography, and there's different kinds of fractures. A compression fracture is just like it sounds. A compression has occurred and the bone has kind of collapsed. This is very common in the spine area. So compression fractures happens a lot in older patients where the bones are lacking calcium and they start to compress down. So compression fractures. An open or a compound fracture means that the bone has pierced through the skin. A simple fracture is a fracture through a bone, but the bone has not pierced through the skin. A green stick fracture, this generally occurs in children where their bones are more pliable. With a green stick fracture, you get a break on one side of the bone, but the other side of the bone is still intact. They call it a green stick fracture. If you imagine going out to a tree, a living tree, taking a branch off and then bending the branch. The branch may break on one side but remains intact on the other. This is called a green stick fracture. A transverse fracture is just a fracture through the bone itself. A spiral fracture or an oblique fracture kind of spirals around the bone. Unfortunately, you see this in a lot of cases of child abuse where there's been twisting motion and you get a spiral fracture. A comminuted fracture is a fracture in which the bone has shattered. So you have the bone in many different pieces. And then an impacted bone is where the bone breaks and then one portion of it slides into the portion beyond it. This is called an impacted fracture. Anatomic relationships. Okay. When we move toward the point of attachment, we say that this is proximal. When we move away from the point of attachment, this would be distal. So in this case, we've got the leg. So imagine where the leg is attached at the hip, right? So if we are moving toward the point of attachment, we are moving proximally. If we're moving away from the point of attachment, we are moving distally. So proximal refers to parts nearer the point of attachment or origin. Distal refers to parts farther from the point of attachment or origin. We can also talk about this, and this is what they mean by origin. Let's take your digestive tract, for example. It begins with your mouth and it ends at the anus. Well, the mouth would be the beginning. So what could we say about the anus? The anus then would be distal. The mouth would be the most proximal portion. Common radiographic terms. Okay. When we're taking x-rays, we angle our beam very often. And we angle our beam, and we'll learn about this more in upcoming courses, but in the body, when you're x-raying things, a lot of things are going to be superimposed. So in order to avoid the superimposition, we angle our beam. If we angle the beam towards the patient's head, if we angle towards, not exactly at the head, but towards the head, we are angling the tube cephalad. You can say cephalic or cephalad. If we angle the beam towards the patient's feet, okay, not right exactly at the feet necessarily, but towards the foot end of the patient, then we are angling the beam in a caudal direction. So we have cephalad and we have caudal. Common radiology terms. Okay. Here on the left-hand side of your screen, we see the patient standing upright. So some x-rays we do, the patient is upright. Some x-rays we do with the patient lying down. If they are face up, we call this supine. It's not pictured here, but if they are lying face down, that's called prone. And any position where the patient is lying down, whether it's supine or prone, we can also say the patient is recumbent. So the opposite of upright is recumbent. And then we could take it a step further and we could say, is the patient lying face up? Okay, they're recumbent, but if they're lying face up, they're supine. If they're lying face down, then they are prone. If they are laying on their side, and notice the film there, the cassette, it's behind the patient and the beam is coming in horizontal. That squiggly line represents your x-ray beam. Then we say that this is a lateral decubitus. Radiographic projections. When we look at these pictures here, let's take a look first of all at the pictures on the left-hand side of your screen. When we say projection, we are talking about where the beam enters the body and where it exits the body. Now, the front of the patient is called the anterior side. The back of the patient is the posterior side. So when I look at the pictures on the left, the beam, which is this line that's drawn, is entering the patient's anterior side, and it is exiting the posterior side. So we say that this is an antero-posterior projection, or AP projection. It enters the anterior, it exits the posterior, so we say that this is an AP projection. Projection, put this in your brain, projection means where does the beam enter versus where it exits. Now let's look at the two pictures on the right-hand side. Now on the right-hand side, what do we notice? We notice the beam is entering the patient's backside, which is their posterior side, and it's going to exit their anterior side. So this is known as a posterior-anterior projection, or a PA projection. So once again, on the left, the central ray, the X-ray beam, is entering anterior, exiting posterior. That's an AP. And the pictures on the right, the beam is entering the posterior side, exiting the anterior side. This is a PA projection. Another type of projection is where we angle the beam through the body. Anytime that the beam is angled through the body, we say that this is an axial projection. Sometimes with our beam, we come and we skim the body part. And this is a key word to remember, skim, S-K-I-M. If we skim the body part, this is known as a tangential projection. So axial means that you're angled. Tangential means that you skim the body part. So in this case, the tangential, you're skimming the cheek area of the patient. Tangential. On the picture on the left-hand side, we're going to continue with talking about projections. When I look at this man, what do I notice? I notice that his right side is closest to what's called the bucky, which is that gray structure. It's where the cassettes are going to be put into, or with digital imaging, that's what is going to be known as your detector. The right side is closest. So we say that this is called a right lateral, okay? Now, I could take it a step further. Is the man standing up? He is. So this is an upright right lateral. So we determine it's a right lateral by which side is closest to what's called the bucky, or the place where you're going to put the cassette or the detector. In looking at the picture on the right-hand side, this is the forearm in a lateral position. So it's a little bit different. We don't say right lateral, left lateral. We're just saying it's a lateral position. It's a lateral position of, in this case, of the left side. Okay, you can see where the hand is, how it would be attached. So that would be a lateral of the left forearm. Now let's look at these projections here. Okay. Now, what does projection mean? Projection means where the central ray is entering versus where it's exiting. So in this case, it is entering the posterior side of the patient. Look at the picture above. It's exiting the anterior side. So this is a PA projection, but we have a big but here, okay? The patient is turned. So when the patient is turned, it's no longer just a straight PA. We say that this is a PA oblique. The patient is turned on their side, a PA oblique. Okay, central ray is entering posteriorly, it's exiting anteriorly, and the patient is turned on their side. This is a PA oblique. Let's take a look at this person here. This patient is lying supine, and another way of saying this is a dorsal recumbent. Dorsum is the back part of your body, backside. And remember I told you the patient, when they're lying down, that's recumbent. So this patient you can say is either lying supine, or if you wanted to use different terminology, you could say that the patient is in a dorsal recumbent position. What do we notice now? Now the man is lying face down. So this is prone. The front side of your body is called your ventral side. So you can say ventral or anterior side. So if they are lying prone, the front side of the body is against the table. So they're prone or ventral recumbent. Which side is closest to the table? The right side. Are they laying on their back? No. Are they laying on their stomach? No. So we say that this patient is in a right lateral recumbent. They're lying down recumbent. They're not on their back. They're not on their stomach. They're on their side. So we say which side is closest to the table? In this case, it's the right. So this would be a right lateral recumbent position. Let's look at this man. Which side is closest to the bucky? The left. Is he laying down? No. So it's an upright. His chest isn't against the board. His back is not against the board. So he's in a lateral position. So this would be a left lateral upright. A left lateral upright. In this picture, we see that the man is lying so that his head is lower than his feet. Whenever the head is lower than the feet, we say that the patient is lying what is called Trendelenburg. Trendelenburg. If the feet are lower than the head, then we give this a special name and we call this the Fowler's position. The Fowler's position. So we've got Trendelenburg and we've got Fowler's position. Never understood why they don't put clothes on this patient in the drawings, but they never do. This patient is in a special position called the Sims position. Sims position is often used when we're going to be inserting an enema tip into the patient's rectum. And a specialized position used for gynecological studies, this is called the lithotomy position. The lithotomy position, a specialized position. Let's continue with talking about a section called Radiographic Positions now. So let's look at this. Which side is closest to the bucky? The right side. Patient is upright. So we call this a right lateral, or we could say a right lateral upright. Which side is closest to the bucky? The side that's closest to the bucky in this case is the left side. So we call this a left lateral. Continuing positions. Now, first of all, before we jump into the position, let's talk about the projection. So where is the central ray entering? Well, it's entering his back, posterior. Where is it exiting? His front, anterior. So this is a PA projection, but the patient's not lying flat, the patient's turned, so this is a PA oblique projection. A PA oblique projection. Now, as far as the body position is concerned, take a look at which side is closest to the table. Okay. In this case, the right side is closest to the table. And is the front of the body or the back of the body closest to the table? Well, in this case, the front of the body is closer to the table. The front of the body is the anterior surface. So this patient is said to be lying in a right anterior oblique position. The right side is against the table, the anterior side is against the table, and the patient's not lying flat. They're turned, so this is an oblique. This is the RAO. RAO is the position. The projection would be a PA oblique. PA oblique projection where the central ray enters versus where it exits. The body position is an RAO. Now take a look at this picture. And I want you to try and determine what position this would be. Look at what side is against the table. Is the front or the back side against the table? Well, hopefully you came up with LAO, left anterior oblique. The left side is against the table. The front of the patient or anterior side is against the table. And they're not lying flat, so it's an oblique. This is an LAO position. Projection-wise, it's also a PA oblique, right? It's the same as the RAO because the central ray is entering the patient's backside, exiting their front side, so posterior to anterior, and they are turned. They're oblique, so PA oblique. So do you see if I told you, I want you to go in the room and I want you to do a PA oblique? Well, that's really not enough information, right? As far as how to position the patient, because both the RAO and the LAO are PA obliques. So we need extra clarification. Let's look at this now. Now in this picture, what do we notice? Well, the patient's right side is against the table. Is the front side or the back side closest to the table? The back side. So that's the posterior side. And the patient is not lying flat, they're turned, so they're oblique. So we call this an RPO, a right posterior oblique. Now remember, RPO is the position. Now let's take a look. What is the projection? Where is the central ray entering? Where is it exiting? It's entering the anterior side of the patient. It's exiting the posterior side, and the patient is turned. So this is an AP oblique. So the RPO position is an AP oblique. Take a look at this. Which side is closest to the table? The left. Is the anterior or posterior side closest to the table? The back or posterior side. Is the patient lying flat? Nope, they're turned, so they're oblique. So this is the LPO position. What projection? Once again, it's an AP projection. It's entering anterior, exiting posterior, and they're turned. So the RPO and the LPO are both AP oblique projections. So you can see once again, I wouldn't give you enough information if I simply said to go into the room and do an AP oblique. Okay, you need to know the body position. Is a patient lying RPO or is a patient lying LPO? When you take a body part, such as the lower leg here, and you turn the foot inward, we're saying we're turning the patient or we're rotating the part medially. If I cut the body down the middle, remember I told you that's a mid-sagittal plane. If I'm rolling the body part toward the mid-sagittal plane, that's a medial oblique or medial rotation. If I rotate the body part away from the midline of the body, then that is lateral rotation. So we've got medial rotation and we've got lateral rotation. Let's move on to something called decubes. Decubes. Now, what makes a decube different? Well, I want you to look at the bucky, where the detector is going to be or the film is going to be. And this picture, the X-ray tube is on the right-hand side. So what do you notice about the central ray? It's coming in horizontally, right? It's not above, the X-ray tube is not above the patient. It's coming in from the side, okay? If the beam is horizontal, we call this a decubitus. In this case, the man is laying on his back. So if he's laying on his back, another way of saying the back of the body is the dorsal side. This is a dorsal decubitus. Do you remember what the front of the body is called? What side? It's called the ventral side. So this would be a ventral decubitus. The bucky is on the side of the patient. The beam is going to be coming in horizontally. The patient's laying on their stomach. This is a ventral decube. Now, is this still a decube? Well, it is. Why? Because look at where the bucky is. Look at where the X-ray beam is coming. It's coming in horizontally. Is the patient laying on their back? No. Are they laying on their stomach? No. They're laying on their side. So this is not a dorsal or a ventral decube. How is the patient? The patient's in a lateral position. Which side is against the table? The left. So we call this, and look at the terminology, a left lateral decubitus. Left because the left side is against the table. Lateral because the patient is not laying on their stomach, they're not laying on their back, they're laying on their side. Lateral. And the beam is coming in horizontally, so this is a left lateral decubitus. Now let me ask you this. What is the projection? Is it AP or P? Is it AP or PA? Well, the central ray is entering anterior, it's exiting posterior. This is an AP projection. This is a specialized projection we do for the chest area. And with this projection, we've got the patient, and instead of standing nice and straight up against the upright bucky, they're leaning backward. We call this a lordotic position. So when the patient steps away from the bucky and leans backward, this is called the lordotic position. And now some body movement terminology. When I bring the arm towards my body, this is called adduction, like I'm adding to the body, right, and bringing it closer to it, versus abduction. Think about the term to abduct. If I abduct somebody, I take them away, right? So if you bring the arm away from the body, that's abduction. So we've got adduction and abduction. if I decrease the angle, so put your arm, your forearm, and your humerus at 90 degrees. Okay. Now, if I bring my hand toward my shoulder, I'm decreasing the angle. That's called flexion. If I go back to 90 degrees with my forearm and my humerus, and I bring my arm down, I'm increasing the angle. That's extension. So we've got flexion and extension. When I turn my hand palm up, this is called supination, or I supinate the hand. If I bring the palm down, this is called pronation, or I pronate the hand. We can also flex or extend the spine. If I'm doing the cervical spine flexion, I would bring my chin down toward my chest. Extension, I would bring my chin up away from my chest. So hyperflexion, hyperextension. When I move my foot inward, that's called inversion. When I move my foot outward, that's called eversion. So invert the foot means to bring my toes in toward the midline of my body. Evert my foot means to bring my foot away from the midline of my body. And here's the act of supinating again. Supination versus pronation. If I move my hand all the way in a circle, well, this is called circumduction. Circumduction. Circum meaning around. If I've got a body part and I take it and I turn it a little bit, I say I tilt the body. So a tilt. And then with the hand, if I take my hand and I turn my fingers outward, that's called ulnar deviation. If I turn my fingers toward the opposite way, that's called radial deviation. So we've got ulnar deviation and radial deviation.